Yes, we are live on YouTube. This is Ranjit Sahu, marketing head with Walter Boston Initiative Division. Welcomes you to the live webinar on PCOS and infertility. We have with us Dr. Jatan Trivedi. With this, I hand over to our medical expert, Ms. Sivangi, to take it forward. Sivangi, over to you.
Thank you, Ranjit sir. A very good evening to all of you. I am Shivangi Chauhan, working as a medical information executive at Walter Bushnell. On behalf of our organization, I'd like to welcome our speaker, Dr. Jatan sir, and all attendees for their valuable time for this important webinar on PCOS and infertility. It is my privilege and honor to introduce Dr. Jatan Trivedi. At present, he is a consultant at New Life Women's Hospital, Ahmedabad. He offered expert services at Kikani Trust Hospital, Bhuta Trust Hospital, and Mehta Hospital, Bhavnagar. He experienced more than 700 hysterectomies and laparoscopic surgeries. His special interests include laparoscopy and infertility. So without taking much time, now I request Dr. Jatan sir to please proceed with the session.
Okay, thank you. Thank you, Shivangi, for your introduction. Am I audible? Okay.
Yes, sir, you are audible.
So as today's topic is polycystic ovarian disease and infertility. So we'll restrict ourselves for the infertility in the PCOS part. As we all know, there is a ongoing pandemic going on, not just of the COVID, but PCOS has drastically increased in last few years because of the lifestyle factors that are affecting with the PCOS. So it is a heterogeneous disorder, and the symptoms mainly consist of hyperandrogenism, ovulatory dysfunction, polycystic ovaries. So all these three in variable formats are causes polycystic ovarian syndrome, and the definitions are keeps on changing over a period of time. Previously, when we used to in our MBBS, we used to follow the Rotterdam criteria, in which 2 out of 3 are required for labeling a patient of polycystic ovarian syndrome. But now, after 2006, Androgen Access Society has changed or revised the diagnostic definition of PCOD, and hyperandrogenism is considered as one of the required criteria. Other oligomenorrhea and polycystic ovaries are not essential for labeling the PCOS. Now there are variable phenotypes for the disease, in which phenotype A is the most severest form, in which everything are raised, including androgen levels, ovarian size, AMH, body weight. And the mildest form is phenotype D, in which there is not much of obesity, there is not much of insulin resistance. So patient can range in the spectrum from phenotype A to phenotype B, C, and D onwards. So we have to really vigilant in labeling a patient for PCOS in our OPDs. Now coming to the etiology, there is a long debate, and there is long survey going on for the etiology of PCOS, and one of the foremost etiology is genetical factors, but especially which gene is causing the disease and what is the which gene is responsible is yet not isolated. But there are some environmental factors from prenatal period, including IUGR, and postnatal factors like obesity, in fetal placental malformation, maternal malnutrition, and fetal hypoxia, as well as genetical familial predisposition are the one of the causes that causes the fetal excess glucocorticoids, and that oxidative stress eventually leads to increase in the glucose intolerance, increase insulin resistance, and dyslipidemia. All this eventually leads to hyperandrogenism, anovulation, and polycystic ovaries. So according to the age for a newborn or even infants, it is it manifests as IUGR, or the small for gestation age baby. Then in their early childhood, the presentation can be like excessive catch-up, postnatal catch-up growth, premature adrenarche, premature puberty, premature menarche, and in their adult life, they may have little excess weight. There are skin manifestation of hyperandrogenism like acne, seborrhea, acanthosis, hirsutism, and they may have little delayed or oligomenorrhea. In their 30s and 40s, they may have obesity, they may have glucose intolerance, infertility, and pregnancy complications. And in the later on, in their later life, the long-term manifestations are like type 2 diabetes, dyslipidemia, hyperandrogenism and dyslipidemia, cardiovascular risk, hypertension, and risk of endometrial cancer. So the prevalence is, as the ultrasound facilities are improving all around the world, we are more diagnosing the PCOS than any time before. And experts in India claim that 10% of women to be affected by PCOS, and yet no proper published data are available. But this is the one of the foremost hormonal problem in women in India, not in India, all over in the world. The PCOS is the one of the foremost hormonal problems in the women. Now coming to the fewer treatment modalities that we are going to see today. What are the treatment modalities available and what all possible things can we do? We will concentrate on each of these, starting from lifestyle modification, weight loss, exercise. Clomiphene citrate is the time-tested medicine and being used since quite long now. Then aromatase inhibitors, metformin or insulin sensitizers, gonadotropins, laparoscopic ovarian drilling, and IVF. Now coming to the treatment part.
Sir, sorry to interrupt, sir. The slides are not visible, sir. Have you shared slide share?
Okay, my slides are not visible.
Ranjit, sir, it is visible to you, sir?
I can see my slides.
Not visible, sir.
It's not visible, sir. Can
Okay,
you share the slide? Yeah, it's not visible, sir. It's...
Okay. Shall I share the screen? I think I have shared the screen. Just give me a second, I'll share it again. Is it visible now?
Yes, sir.
Is it visible now?
Yes, sir.
Yes, it's visible now, sir.
Okay, okay. So
Can we make it full screen, sir?
I'll make it. So we were on the treatment part of the polycystic ovarian syndrome. The pre-treatment is requisite for all patients, whether they want to go for fertility in whatever part. The pre-treatment, and that is mainly lifestyle modifications, consists of diet, exercise, and weight loss thing. First line medicines are commonly used, clomiphene and letrozoles. Second line is gonadotropins and laparoscopic ovarian drilling, and final is the IVF. Weight loss, I will say the obesity, as we know, is a BMI of more than 30. There is a high risk of all obese women to develop PCOS, maybe now or in later part. So all patients should be tested for insulin resistance, and all those who have it or having insulin resistance and hyperinsulinemia are likely to develop PCOS and complications later in their life. So they are encouraged to do weight loss before enrolling for any mode of treatment. And if they can achieve at least 10% of the weight loss, there is increase in the success rate of even IVF and non-IVF cycles. I would like to even suggest that there are pharmaceutical agents available to that will help you to reduce your weight that are also advisable, and especially the diet charts, motivation, group counseling, all these things are going to work, and patients should be encouraged in every meeting. They're counseled, they should be motivated, and at least 6 months they should do some rigorous weight loss therapy so that the outcome of infertility and early pregnancy complications can be reduced. So aim is, as I said, at least to reduce 5 to 10% of body weight before starting the therapy. Physical activity in form of mild to moderate exercise for at least 30 minutes in a day. Low carbohydrate, high fiber and high protein diet. Avoid smoking and alcohol, and avoid stress. Now coming to bariatric surgery, some women of more than 100 kgs and more than 30 BMI, they find it very difficult, extremely difficult to lose the weight, and in that cases, the bariatric surgery helps in quite a way. Bariatric surgery not only just cosmetically improves the patient, but also effectively attenuates the PCOS, and clinically and symptomatically, including the hirsutism, including the insulin resistance, and including the menstrual irregularity. So there is a significant improvement in the symptoms in morbidly obese patient, and bariatric surgery is going to help them. Now coming to the second line of medicines, as I said, first line is for everyone. So all women, those who are going for second line, should have first line lifestyle changes in that. Now coming to the second line, letrozole and clomiphene citrate. These are the medicines, and clomiphene is the time-tested medicine that has been used since now, more than 10 years or so. And it is the first line that has been used for ovulation induction, and there are many trials available to compare the one from the other, and there are many studies that say one is better than other. But in the brief, what I can say is, as from our experience, the live birth rate of clomiphene and letrozole is comparable, but because of the anti-estrogenic effect of clomiphene citrate, the ovulation rates are the pregnancy rates are less in clomiphene citrate group compared to the letrozole group. Otherwise, the multiple pregnancy rates are also higher in clomiphene citrate compared to letrozole. Letrozole mainly causes monofollicular growth, and clomiphene tends to co multiple follicular growth and can cause multiple pregnancies. Now, micronization is a new technology. Now, we have seen it, progesterone micronized, estradiols are micronized, as same way. Clomiphene citrates are also available with micronization technology that reduces the particle size and that eventually increase the bioavailability. The letrozole regimes are now, there are extended regimes. We used to give for 5 days, and now there are low dose 10 days regime also available. So that is that can be used in patients who find it clomiphene citrate resistant. So letrozole can be used for extended days in dose of 2.5 to 5 milligram. When there is no pregnancy achieved despite of ovulation, if we give clomiphene or letrozole, so if patient ovulates but there are no pregnancy, then we label it as a failure, and the failure is mainly due to anti-estrogenic effect of the clomiphene in the cervical mucus and in the endometrium. So in case of failure, we rectify the anti-estrogenic effect by giving estradiol, we give sildenafil, we give aspirins, but we can also step up to gonadotropins for ovulation induction. Also, we can encourage to reduce weight if there is failure. We can correct the hyperandrogenemia. We can give dexamethasone in the cycle. We can add metformin, insulin sensitizer. OC pills can be given pre-treatment for 1 or 2 months, and at the end we can use laparoscopic ovarian drilling. So clomiphene citrate failure or letrozole failure can be given an option of laparoscopic ovarian drilling. Coming to the third agent, that is metformin. Metformin is also one of the time-tested medicines, and it has been documented in many trials. Metformin alone cannot be used as a first-line medicine, but it is an adjuvant therapy to be used along with clomiphene and letrozole, and it increases the glucose intolerance. It improves insulin sensitivity, and it helps in ovulation. So it is one of the key adjuvant therapy that is used in the ovulation cycles, and data is now even showing that continuation of metformin even after getting pregnancy for early pregnancy is important in prevention of early complications. Now coming to the third line therapy, that is gonadotropins, in which there are urinary gonadotropins, highly purified one, and recombinant gonadotropins are available. Those who patient fail to achieve ovulation in spite of using adjuvant therapy and clomiphene and letrozole are advised or encouraged for gonadotropins. But there are some criteria that ultrasound monitoring is must. There are several protocols, step up and step down. But the polycystic ovarian patients are prone for hyperstimulation, and they are extremely sensitive for the hyperstimulation. So the low dose protocols are encouraged. Low dose FSH protocols are to be used along with ultrasound monitoring. Pregnancy rates are around 25% per cycle. Because of high number of antral follicle in the PCOS, they may need cycle cancellation, or they may need the risk for ovarian hyperstimulation. So that is the risk factor for using gonadotropins. Also is the cost, because there are these injections are to be used subcutaneously, and they are to be used in daily or alternate day doses. So the cost is important, monitoring, and risk of multiple pregnancy and ovarian hyperstimulation. As I said, the low dose regimes are important, as there is a threshold of ovulation. There is a threshold of response seen in PCOS. So there is an all or none response. The woman may have zero response, or she may have an exponential response. So we need to just reach the threshold for using the gonadotropins, and that is very important. If you can, if you overshoot it, one may land up in ovarian hyperstimulation. So this is a very common diagram we have seen. The chronic low dose step up. Instead of HMG, we use FSH here, and we start from 75. We do it for 5 days from day 2, and then we do the sonography, and then we monitor the response. We can increase from 75 to 150, and again we monitor. Then, if at all needed, we can use antagonists, that is injection cetrorelix. If there is premature LH surge, if we feel that multiple follicles are growing, then we can use cetrorelix, and we usually give HCG 5000 to 7500 at around 14 to 15th day, and when the follicle size is more than 18 mm. So every 2 to 3 days we have to use the ultrasound. Comparing the urinary derived gonadotropins and recombinant, there is not much difference in the live birth rates. though the cost is very high in recombinant, and but yeah, the live birth rates are comparable in both of this. Systemic review found there is no evidence of difference in live birth rate in or ovarian hyperstimulation among the patients with PCOS who were treated with either urinary or recombinant. Risk of multiple pregnancy and ovarian hyperstimulation cannot be completely eliminated in either of these. Both of these can cause multiple pregnancy and ovarian hyperstimulation. So patients should be counseled regarding the risk of hyperstimulation as well as multiple pregnancies. As we know nowadays the pens are available in recombinant, so we can give as low as 37.5 international units, and the lower dose are good for giving a monofollicular growth. So the lowest possible dose to achieve the threshold is needed, and all those who are given gonadotropins, the luteal support is must, and luteal support is should be given with progesterone rather than with HCG. Now coming to the laparoscopic ovarian drilling, there was an era when the laparoscopic drilling was not being used quite often, but now it is again back in the track. Previously, the wedge resection was done by Steve and Neventhal in early 1950s to chop out the wedge of the ovary and to reduce the bulk of the ovary. But nowadays we are using the laser and cautery to create punctures and to reduce the bulk of the ovary. We usually do 5 to 6, not 10, 5 to 6 perforation in per ovary. So after the laparoscopic ovarian drilling, 80% of patients ovulate. There is no difference found in the rate of miscarriages, ongoing pregnancy, and live birth rate. There is very fewer cases of multiple pregnancy in comparison to gonadotropin therapy. The drilling causes release of androgen-rich follicular fluid and decrease the androgen-producing stroma. There is transient reduction in inhibin and fall in LH that eventually increases the expression of FSH. The crowding of cortex decreases, which allows the normal follicle to come out to the surface and resumption of ovulation. So laparoscopic ovarian drilling is also as effective as routine gonadotropin therapy, and it improves the live birth rate. There are some concerns regarding adhesions, though it is very minimally invasive, so these kind of adhesions are not common. And ovarian reserve, as we have reduced the number of punctures from 10 to 6 per ovaries, so decreased ovarian reserve is also not drastic, and it's not too much worried about. Now the final part is in vitro fertilization. So when there is absence of absolute indication for IVF or ICSI with PCOS and anovulation infertility, the IVF is considered as a last third line therapy when there are when the first and second line therapy fails. Of course, when there is an absolute indication, it can be considered in the first line, but otherwise it is to be reserved once the other therapies fail. Stimulation protocols, antagonist protocol is usually recommended for PCOS patient. Again, triggering the final maturation is with GnRH agonist, and freezing the embryos is considered in PCOS patient in a view of ovarian hyperstimulation. So these are the things, as I said, use of GnRH antagonist is used during the trigger. We instead of HCG, we have to limit the dose of HCG, or we can use GnRH agonist for the trigger. Prophylactic albumin can be used, and after this trigger, cryopreservation and freezing all embryos and transfer in the subsequent cycle is also recommended in ovarian and PCOS patients. So ovulation induction outcome relevant to the factors. So patient's age, PCOS, how severe, as I said, there are phenotypic patients. So phenotype A is the most severe form, sorry. And there comorbidities, obesities, hirsutism, insulin resistance, and sperm quality. Doctors' experience, dose regime, intensity of monitoring is also vital. Periconception strategies, IVF as an alternative treatment modality, pregnancy complication, and follow-up of all PCOS patients for the long-term complications. So now concluding the lecture today's, what we have discussed is the lifestyle intervention is recommended in all women who are diagnosed as PCOS. And that is, even before starting any kind of therapy, they should at least reduce down to 5 to 10% of their body weight to improve the outcome, to reduce the dose of the agents, and improve the live birth rate. Both clomiphene and letrozole are comparable and can be used as a first-line pharmacotherapy for ovulation induction. Gonadotrophins and laparoscopic ovarian drilling are the second-line therapy when the first line fails. Metformin is alone is not giving very much good result, but is an adjuvant therapy to be used and can be continued in early pregnancy. Those who fail to ovulate in spite of all these are considered for IVF and mainly by GnRH antagonist protocol. If GnRH agonist protocol is used, metformin is an adjuvant and may reduce the risk of ovarian hyperstimulation. So I conclude my today's session. Thank you so much.
Thank you, sir.
Yeah.
That was indeed a very informative and wonderful session. So as of now, we don't have any questions in Q&A. So I hand over the session to Mr. Ranjit Sahu.
Yeah.
Thank you, Shivangi. Thank you, Jatan sir, that you directly touched upon very important topic, that is PCOS, which is a burning topic of nowadays. And
Yeah.
we have simplified the area where we should concentrate upon. It is all about lifestyle modification, which is the prime thing apart from medication. So both should go hand in hand so that to take care of this situation. So it was a very useful talk, and Walter Bushnell stands committed always to be part of you such kind of scientific piece. We remains committed. So future webinars also we like to hear from you. Thank you for getting associated with us. Thank you.
Thank
Have a
you.
lovely evening.
Thank you.
Have a lovely evening ahead. Thank you, sir.